السلام عليكم طلبتنا الأعزاء. أنا دكتورة آلان عيسى سليم and this is my first lecture about iatrogenic effect of tooth movement. Orthodontic treatment have an adverse effect associated with the treatment like other fields in dentistry. First of all, pain. Number 2, periodontal disease. 3, pulp effect. 4, root resorption. 5, decalcification and associated caries. 6, temporomandibular disorder. First, pain associated with orthodontic treatment. Pain and discomfort is a common adverse effect associated with orthodontic treatment. 70 to 95% of orthodontic patients experience pain. This pain could be a reason for discontinuing treatment in some cases. The pain and discomfort associated with orthodontic treatment is characterized by pressure, tension, or soreness of the teeth. Pain in the anterior teeth is greater than the posterior teeth. Management of pain should include informing the patient of the possibility of experiencing pain to reduce anxiety. Furthermore, the clinician can ask the patient to chew on plastic wafers or chewing gums containing aspirin. Additionally, clinicians are recommended to prescribe ibuprofen or acetaminophen analgesics and for short duration after placement of separator and initial wires. Second, periodontal disease and orthodontic treatment. Periodontal disease includes gingivitis, alveolar bone loss, periodontitis, and loss of attached gingival support. The periodontal reaction toward orthodontic appliances depends on multiple factors, such as host resistance, the presence of systemic conditions, the amount and composition of dental plaque, smoking, and the negative effects of uncontrolled diabetes. Bacteria present in dental plaque are the primary causative agent of periodontal disease. Orthodontic treatment with fixed appliances is known to induce an increase in the volume of dental plaque. Therefore, oral hygiene instructions should be given before the initiation of orthodontic treatment and reinforced during every visit. Regularly brushing of the teeth is the first line of defense in controlling dental plaque, in addition to the use of an interproximal brush. Number 3. Pulpal changes during orthodontic treatment. Although pulpal reactions to orthodontic treatment are minimal, there is a probably transient inflammatory response within the pulp, at least at the beginning of treatment. This may contribute to the discomfort that patients often experience for a few days after appliances are placed. The use of heavy, uncontrolled continuous force by the orthodontist or round tipping of the teeth may lead to the loss of pulp vitality, since root apex may move outside the alveolar process. Therefore, orthodontists should use optimal light forces during their treatment. Number 4. Root resorption. Limited root resorption involving a number of teeth can be considered as consequences of orthodontic treatment. The factors which may be contributing to root disease are hormonal disturbances, dietary deficiency, periodontal disease, and orthodontic treatment variables like duration of treatment. The risk for root resorption increases with the length of treatment. Treatment of impacted canine can extend treatment time and increase the risk for root resorption. Thin, tapered, and dilacerated root morphology results in roots that are more prone to resorption. Maxillary lateral incisor. Additionally, history of trauma associated with the anterior teeth increase the risk of root resorption. So, assessment of the condition through a progress radiograph at 6 months after the initiation of orthodontic treatment is recommended. These could be either periapical or panoramic. The patient must be informed that if root resorption is observed, then active treatment must be stopped for at least 3 months. The repetitive process of root resorption begins 2 weeks after active treatment is stopped. At this stage, an alternative treatment plan should be considered, and the treatment should be discontinued when severe root resorption is observed. Number 5. Decalcification and caries associated with orthodontic treatment. Decalcification of enamel, or as we call white spot, is a common adverse effect of orthodontic treatment. Decalcification is considered to be the first step toward cavitation. Decalcification of enamel occurs in 50% of orthodontic patients, and the most affected teeth are the maxillary incisors. Additionally, these lesions can develop within 4 weeks, which is the typical time span for orthodontic follow-up. The prevention protocol for decalcification includes plaque control through brushing of the teeth with fluoridated toothpaste. Daily rinsing with sodium fluoride solution can also minimize decalcification of enamel. Additionally, fluoridated solution may delay the progression of lesions. Application of fluoride varnish twice a year or a combination of antibacterial and fluoride varnish may reduce the incidence of decalcification. Number 6. Temporomandibular disorder and orthodontic treatment. Temporomandibular disorder is a condition that can include masticatory muscle pain, internal rearrangement of the temporomandibular joint disc, and degenerative TMJ disorders as separate problems, or can be a combination. The etiology of temporomandibular disorder is complex and cannot be explained on a cause and effect basis. Malocclusion may be considered in some cases as a contributing factor, but it is not the only etiological factor. Orthodontic treatment during adolescence does not increase the risk for TM disorder. The orthodontic treatment should be postponed after attack is controlled. If the patient develops signs and symptoms during the orthodontic treatment, then all active forces must be discontinued without the need for the removal of the fixed orthodontic appliances. Then the signs and symptoms of temporomandibular disorder must be controlled using a conservative approach. Once the signs and symptoms are under control, then the practitioner must return to the treatment. In some cases, the orthodontic treatment must be terminated if the signs and symptoms cannot be controlled. Now we come to the subject which is related to orthodontic tooth movement, which is the accelerated tooth movement. Methods to accelerate orthodontic tooth movement can be broadly studied under the following categories. First, drugs. Second, surgical methods. Third, physical mechanical stimulation methods. Now we talk about the drugs. Various drugs have been used since long to accelerate orthodontic tooth movement and have achieved successful results. These include vitamin D, prostaglandin, interleukins, parathyroid hormones. But all of these drugs have some or the other unwanted adverse effects, and as of today, no drug exists that can safely accelerate orthodontic tooth movement. Second, surgical methods. The various surgical methods available are corticotomy. The conventional corticotomy procedure involves elevation of full-thickness mucoperiosteal flaps, buccally and or lingually, followed by placing the corticotomy cuts using either micromotor under irrigation or piezosurgical instruments. This can be followed by placement of a graft material wherever required to augment thickness of bone. The advantages of corticotomy: it has been proven successfully by many authors. Also, bone can be augmented, thereby preventing periodontal defects which might arise. The disadvantages of corticotomy: first, high morbidity associated with the procedure, invasive procedure, chances of damage to adjacent vital structures, post-operative pain, swelling, and at the final low acceptance by the patient. Piezo session. The surgery was performed 1 week after placement of orthodontic appliance under local anesthesia. Gingival vertical incisions only buccally were made below the interdental papillae, as far as possible in the attached gingiva, using a scalpel. These incisions need to be deep enough so as to pass through the periosteum and contact the cortical bone. No suturing is required except for the areas where the graft material needs to be stabilized. Patient is placed on an antibiotic mouthwash regime. The advantage of this biosession is minimally invasive, better patient acceptance. The only disadvantage is the risk of root damage. Number 3 is the micro-osteoperforations. This based on microperforation, in which screw-like dose used for skeletal anchorage is placed through the gingiva into interproximal alveolar bone and then removed. It is said that 3 such perforations in each interproximal area are enough to generate a regional acceleration of bone remodeling and thereby produce faster tooth movement. We talk about drugs and surgical methods. Now we come to the physical and mechanical stimulation. Surgical methods, regardless of technique, are still invasive to some degree and hence have their associated complications. Hence, non-invasive methods have come to the fore. These modalities include lasers, vibration, direct electrical current. First, laser. In the last decade, many histological studies have attempted to determine the effect of low-intensity laser therapy on the histochemical pathways directly associated with orthodontic tooth movement. Increased osteoclastic and osteoclastic activity after low-level laser therapy was observed. The variations amongst the studies seem to arise from variation in frequency of application of laser, intensity of laser, and method of force application on the tooth. Number 2, vibration. This device consists of an activator, which is the active part of the appliance that delivers the vibration impulses with a USB interface, through which it can be connected to a computer to review the patient usage of the appliance, a mouthpiece that contacts the teeth. It is a portable device that can be charged similarly to any other electronic device. It is based on delivery of high-frequency vibration to the teeth for approximately 20 minutes per day. Various case studies using this device have shown the treatment times to be reduced by up to 30 to 40%. Number 3, tissue penetrating light. To provide light with an 800 to 850 nanometer wavelength just above the visible spectrum, adjacent to the alveolar bone. Light in this spectrum does penetrate soft tissue, and the idea is that it infuses light energy directly into the bone tissue. This is said to excite intracellular enzymes and increase cellular activity in the PDL and bone, increasing the rate of bone remodeling and tooth movement. Number 4 and the last is the therapeutic ultrasound. It is known that therapeutic ultrasound, which is different from diagnostic ultrasound, increases the blood flow in treated areas. The theory is that increased blood flow in the PDL would increase the rate of bone remodeling and tooth movement, and also could decrease root resorption. This is the end of my lecture. I hope you will like it. Thank you for your listening, and I'm ready for any question. Thank you very much.